right, welcome to the first meeting of the series of respiratory education of hemodynamics in preparation for the ECMO. The ECMO. Oh, worked perfectly. Okay.
That was me, sorry, I just did it.
There's the marker here. Okay, so everybody, we have the Zoom on, we have the video on, right?
Mm-hmm.
All right, we can start. So this, guys, is gonna be very basic. We're gonna start with the basics, right?
Yes.
Because it's important to start with the basics. I'm not gonna even mention the word ECMO today. It's just gonna be just basics, hemodynamics. All of this, the equipment here that you see, you're not gonna touch, most probably, but you know what it is. You know what the nurse does to troubleshoot them, and also will know what to do with them and what they do, the function of those lines. So that we'll start with this. I'll talk about the A line in a second, but let's just start touching these, and you can keep them with you, so you can know exactly what. This is the central line, right? Obviously, you've seen the central line before. This part goes inside the patient. This part is very sterile, and actually the yellow indicate that there is maybe some, or sometimes different color, but there is like a material that, like a sulfur based, that actually makes it less prone to infection. And these end here, we don't use those, obviously. They use, claves, which you can attach the medication to in this area here and in those areas, right? There are 3 lumens. The brown ends at the tip, right? And that's 16 gauge. It's like a 16 gauge IV, right? You know the IVs is 20 gauge is the smallest. I mean, 22 is the smallest. 20 they go the opposite, right? So 22 is the smallest, 20 is a little bit bigger, 18, and then 16. This is 16 gauge. And then there's lumens you're gonna see on the sides here, right? One here and one here. So one opening here and one opening here. This opening here is called the medial port, which is the blue, right? And then the white is all the way distal here. That's the distal port, right? So when we place something like this, we ask the nurse to monitor the CVP. So the first thing they do, they attach the monitoring, which I'm going to show you in a second, here to the brown port, and that's where the vamp is, and that's where they draw the VBG and all the labs and everything. So monitoring and drawing usually happens from the brown port, and then this blue port, you can use it for any infusion, right? It comes from the side. And then the white port also, you can use it for any infusion, depending on what the nurse wants. Both white and blue are 18 gauge, so smaller. The biggest one is the one in the middle, And so if you want to give lots of volume, blah, 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 that goes through the brown. The smaller, this is only for medications and things that go on pumps and stuff like that, right? All of the lines in this hospital now have this like a butterfly thing, like these 2 wings, which indicate that they are power lines. They can be used for CAT scan. CAT scan inject at a very high speed, and regular lines can break, flick off the tip, right? So these are lines, are power lines. To me, they're the same. I think they're the same. They're just like they added the wings and they made more money. That's it. Between you and I, between you two. But anyway, the point is, one just troubleshooting, just because you'll be involved in something like this. ECMO guy, blah blah blah. Big patients, patients who are obese or have a huge chest or something like this. When we put this line, what is the line that you're worried about the most? That it's not inside the vein, that could not be inside the vein, potentially, is the white. The brown, you already had placed the wire, there's a wire that is used, the wire goes inside the patient first, that's for placement. The wire goes inside the patient first, and then the line, after dilation, the line goes through it like this, goes over it like this. Right? And it comes out from here, and you keep advancing like this until you leave it inside the patient. But so the brown, you guaranteed it's in because the wire was in, right? The blue, typically it's in. The white is so far out. See the difference between this and this is like 3 centimeters or so. So if the patient is, have a lot of subcutaneous tissue, the tip could be in, the side could be in, but the last one, the proximal port, so the white, sometimes we tell the nurses, this is a 20 centimeter line, by the way. Typically we use 16 centimeter line. This is a 20 centimeter. 20 centimeter meaning that we use those for patients who are extremely obese or something like this. That's important for them, for that, and it makes sure that the white is in. If we're still having suspicion, or we don't have a 20 centimeter, sometimes we don't have it, and we have to put a 16 centimeter in somebody who's obese, what we're gonna do, we're gonna tell the nurse to, every shift, she has to check this white port, otherwise the medication is gonna go in the subcutaneous tissue, right? So this is your central line, and inside this kit, you'll see things like this. You're not gonna be here when we place it, but this is something to measure the pressure as we're placing it. When we put the needle in, we put a little bit of a small angiocast, so it doesn't really hurt the patient, and measure the pressure like this to make sure, oh, it goes down. If it goes down by gravity, that means it's a vein. So now we're gonna dilate using this dilator that goes over the wire, dilate, make room for this one, and then go with this one. Right, so that's the process. Obviously, you get the line with this needle, right? I said I'm gonna mention ECMO, but I'm gonna mention ECMO. This one, just to have a comparison. This line here is 8 French, right? Is 8 French. French is a way to measure things, and it's used for chest tubes, it's used for lines like this and stuff like that. It's different than gauge, right? So so anyway, so 8 French, and the ECMO line that we have to put in is 22 to 24 French. So it's 3 times this line, right? Which is not a big deal, but you'll see as we're placing it, there's multiple dilators. There's not only one dilator, there's like 5 dilators. 1, 2, 3, 4, until it becomes, the hole is bigger, so you can go through the whole thing. All right? This is your kit.
Is it comparable to the HD line?
What's that?
Is the HD line the same line as the
The
ECMO line?
HD line is 14 French.
Okay, so it's even bigger
The other
than
one
the
is
ECMO.
23 French, or so basically, the HD
Okay.
line is a little bit it's double this, and then the ECMO machine is double or a little bit close to double the HD line, right? So the intimidation here is just bigger line, And when we do the HECMO, hopefully we'll have a smaller catheter too. The HECMO is half ECMO basically, and we'll talk about that when the time comes. So that's the central line. Okay, let's talk about the A line and central line together, and we'll talk about the way it's being monitored, and then I'm going to move on to the swan, because everybody's going to have a swan, right? Okay, so the A line, you guys know how to place A line. Everybody you probably studied in school how to put an A line, how to monitor A line, all of these things, but we'll just go over it again. The A line is usually placed using a different kit than this, similar. Usually we do it with ultrasound, usually it's radial, axillary, brachial, femoral, or other things. But anyway, so the A line now, you place the A line, or we place the A line. It's being monitored. I want you to troubleshoot one thing for me. I want to go over one thing, maybe after we talk about the monitor. Okay. So the A line now is having a waveform, and then the nurse will give the doctor or the provider this end here. This is how we monitor the A line. Okay. This part here goes through in a bag, 500 cc. Usually saline. It's not heparinized saline. We used to do heparinized saline in the past. We moved away because of the hit, the allergy to heparin, right? So now we do saline. So we just spike the bag. This has to be a drip chamber. There has to be some fluid here. If there's no fluid, there's a problem, right? It has to be fluid, right? Half of it. This has to be open, and it goes like this all the way down here, like a regular IV, and then it meets this part here. This part here is a transducer that measures the pressure. That's the apparatus that measures the pressure, right? And there's a stopcock underneath it, and I'll tell you why we have a stopcock. And then of course it comes directly from the transducer, this cable here, to be connected to the cable that comes from the machine, and that gives us the measurement, right? Now, look at this. So right now, from the transducer down, this goes to the patient now, right? Feel this tubing here, and feel this tubing.
Oh, yeah.
There's a huge difference, right? This is a very hard tubing, you can't compress. This is easy to compress. So this is called this one in my hand here is called non-compliant tubing. And non-compliant tubing meaning that it doesn't take the pulse and just expand. Like this one here, it takes the pulse and does like this. So it's not gonna be good if you're measuring, you wanna measure pressure here, it's not gonna measure. This one measures pressure. So that's important. If you identify that somebody brought somebody from the OR or from the cath lab, and we're measuring pressure, and then sometimes, some people put an extension tubing here between that and the patient, and they use this type of tubing. That's wrong, right? We need to. Also, some people connect this, right, to a clave. You know, the blue one that we put, you can't. The clave already has a valve in it and stuff like that. You don't want to do through the valve. It has to be connected directly through here. Through the opening of the central line. You remove this white thing and it just connects directly like this, right? Or the A line, same thing, right? Right, so what's this? That's the vamp. That's horrible. That's horrible. I hate the vamp. But the vamp basically is what we use here in Brockton Hospital. When I was at Bellevue and at BI until now, they exchanged the vamp. The vamp is more recent, obviously. They actually have two stopcocks, right? So imagine, I want to draw gas. So there's two stopcocks here, or whatever. And then, you open one of them, draw 10 cc's, and then you open the other. Now we fill this with blood now, so there's no, and now you draw the other, which is the gas. You send it to the gas, and then inject back the 10 cc's that you drew for this card, right? You got it? You get what I'm saying, right? You're gonna inject the discard back again and close the stopcock and flush. So everything goes back into the patient, but you have to take the two syringes and throw them away. You can't reuse the two syringes because once you pull this like this and you push it back again, and then let's say I put shit here, like I took patient's shit and put it here, right? And inject like this. I mean, my attending did this experiment, by the way, put shit on the thing. And inject back again, nothing is gonna go inside the patient. The shit is gonna be between the blue and the inside of the, but if I do this again, now it's inside. Right? So it's only once, you pull it out and then you push it, that's it. And then you discard it. So for some reason they didn't want to do that, so they added the vamp. The vamp is like a syringe, consider it as a syringe. You press it from both sides like this and pull up. So it pulls from here and fills this part here with blood. But there's a condom here. You notice this condom here? So I can push it back again and do it multiple times. So there's no dirtiness that's gonna go in between this and inside, okay? So that's good, right? But where do we draw? We draw from here. So the gas comes from here. So you come out like this, and then you draw the gas from here, okay? It's fine, it works all the time, the nurses know how to do it and everything, but there's one problem with it in the design. I told the company, if this stopcock here, they have to make it a stopcock with an opening like this one. Because what end up happening, if somebody draws so quickly on this, it creates a negative pressure, right? The negative pressure has to be satisfied with blood coming out. If it's not satisfied with blood, how is it, what fills it? Air. So it fills with air through the crevices. Imagine the air actually goes around the catheter. This is the catheter going inside the patient like this. This is inside the patient. The air goes like this and gets and run next to the catheter, and then goes into the catheter into the vamp. Right? We don't see it obviously, but we see this filled with air. What do we do with filled with air? You can't do anything. You have to disconnect it from the patient, or you have to draw from here. It's really cumbersome. But if you have a stopcock here, you can get it out. regardless, this is what we have, so just be careful when you draw, don't draw too fast, draw a little bit slow, and this way you will be able to fill it without filling it with air, and then and everything will work fine. Right, now, let's go, so that's the whole thing, right? We'll go back to this one because that's important here. This is what measures the pressure, right? But also has another function. It allows 3 cc's per hour to pass by, just 3 cc's per hour. But it has to be pressurized. So you notice the bag that is here has a pressure bag around it that's pressurized to 300. By the way, you can take your mask off if you want. It's up to you. I mean, we're not in a clinical area, so. Anyway, so it has to be pressurized to 300 cc, 300 millimeter of mercury, which is higher than any arterial pressure, right? But it doesn't go. Nothing goes. 300 millimeter of mercury, but this allows only 3 cc's per hour to go through, right? Just 3 cc's per hour. If I do like this, pull this out like this, that opens it completely and directly connect the 300. Is this the burrito? This is the burrito. This is one of the burritos.
That was number 3.
Number 3, okay. Wow, it looks amazing. And he's interested.
I know.
He's gonna be a respiratory therapist. She's gonna take over the whole department. She's not gonna need to hire anybody. Nice. What's his name?
Amias.
Amias. Hi. Amias.
It's nap time.
It's like,
Oh,
It's nap
He's asleep
time.
Wow. All right, so you got that? So if you pull this, you have it flush. So that means if there's blood here, or the thing is not drawing, or the thing is not giving you the wave that you want, you just flush, and it flushes completely. And there's other things that we do to, so what, you can pass those around if you want.
So when you flush this, I mean, because we've done them in clinicals,
Yeah,
it clears, it goes back into the patient?
Yeah.
Okay.
right? The bag itself is essential for flushing and essential to maintain the A-line patent. But it's not essential to measure the pressure. Like if you don't have a bag, you're still gonna measure the pressure, right? So before we, so I'll get into the measurement in a second. So how's the nurse do it? Actually, you have to put the stopcock level at the level of the mid-axillary line, right, which is the right atrium, usually. When you do that, then you open the stopcock in a way to actually separate it from the patient. So basically, if this is going to so this is coming from the bag here,
Yeah.
going like this, right? This is the stopcock here, and this is the transducer. Okay, so and this is the sign here, it goes like or the liver here, right? So and this is the patient, right? We're going to the patient here. So you open this like this. So now now it's open to air, right? To zero it, right? So if you open like this, I'm sorry, to open like this, I'm sorry, the other way. Like I have to do it on the thing itself. She gave me one that doesn't work. Right. So it goes like this. If you close it like this, so basically the transducer is directly connected to the air. So air will go like this and stimulate the transducer, right?
That might be a dry erase marker.
It's permanent.
Oh, is it
No.
permanent? Oh.
Can you? There's nothing here.
Do you want me to go out and see?
Yeah,
if they have-
can you go out and just ask him to say we need a dry erase marker? Thank you.
Yeah.
Alright, so if it goes like this, imagine air goes like this and goes up to the transducer. So basically,
Wait.
the got it. We got it, Angie.
Oh, you got one, thank you.
Mhm.
Knows what to open. Alright, so here, this,
Oh, don't touch.
you're gonna be kidding me.
I know, okay, though.
Oh.
So if it opens like
Really?
this, so now air is free to go like this, right? And it hits the transducer, and then you tell the machine, the monitor,
Yeah, we need an.
zero. Right?
Yeah.
You don't monitor. So basically, what you're basically doing is looking at it and see what is the transducer. The transducer is here. I want the air to go into the transducer. So open it like this. So basically, you're closing it to the patient, and the air is going like this now, right? Because this means off. It's written on it, off. So that means going here, and then you tell the machine this is the zero. So you have it like this and telling this is the zero. Consider this the zero, and then it will measure after. Before you do that, you will have a waveform, but the waveform is not gonna be. It's not gonna be. By the way, I forgot to tell you, we have a drink after this. As soon as we're done, I forgot to say. As soon as I'm coming here, I'm going up to the drink. So I'll take one of you.
Oh my
I'm
goodness.
sorry. I'm sorry, or one of you guys. So, right? So we'll do like, right? So, what was that? What was I saying?
The zero.
You're zeroing
You were
out.
zeroing
Yeah.
the.
Yeah. So you zero it like this, but it has to be at the level. Whatever you before. Oh, sorry. What I was saying is that before you tell the monitor that this is a zero, the monitor is going to give you a waveform. The waveform is going to be there, but there'll be no number. There'll be no measurement here. You're not going to see a number. But once you put the zero, then the machine is going to keep the waveform and tell you the number is, the blood pressure is X, Y, and Z. Right? Now, this is very important, right? If for an A-line, for example, is measured like this, right? And this is something that we're going to be dealing with all the time for ECMO. The A-line is going to be an important thing. And it's zeroed already, so, and then the patient has a A-line here and staying no problem, paralyzed, whatever. And this falls on the floor. It happens, right? What will happen to the blood pressure? Will it go up or down? The measured blood pressure on the machine.
Yeah.
It's gonna go up. Because imagine all of that column of air or blood or whatever, all of that column of fluid is now affecting the transducer, saying that blood pressure is high, it's all the way up here. Right? So the blood pressure will be higher. So we've seen cases where people actually manage the patient, give him sometimes antihypertensives, but didn't notice that this is on the floor. Or they didn't notice that somebody raised the bed and this stayed where it is. So that's very important for the nurse to keep him just like changing this. Sometimes it changes so much, or the patient has a controller or something, keep changing. You just tape it here. It's not ideal, but we just tape it and say, okay, so this way, if he moves, at least we know it's staying. So that's very important. If it comes up, the blood pressure will look like it's low, right? So how about this? This is leveled here, and I have a radial A-line, and then I raised my hand like this, 20 or 30 centimeters above my heart. Will the blood pressure be lower or higher? The same. That's a trick question. That's a trick question.
Can you repeat the question?
If I have this connected and leveled at the level of the stopcock, right? And then my hand and everything, circuit is the same. Everything is the same. Nothing is disconnected or anything. I'm just raise my hand like this. Will the blood pressure be lower or higher? The blood pressure will be lower if it's a cuff.
Right.
If I'm using a cuff on my hand and raise my blood pressure, the blood pressure will be lower. But for A-line, no. Why? Because it's all about this, not about anything else. So for example, raising my hand will be no different than taking this, for example, and raising it up like this. It's not going to change anything. It's a column of blood that is leveled at this level. The only thing that matters is where this level is. I can raise this, I can turn to the side, I can do whatever I want with where the A-line is going, but as long as the column of blood measured at this level of the atrium, right atrium, is at the same level, that's what we need. Okay, so we troubleshoot all of those stuff, right? For central line, also the same. We use the same thing. It's just a little bit. The changes in central line could mean more stuff. Could mean more.
Now you want me to use
Oh yeah, I'm going to use this. Perfect.
Okay.
Right. So let's right now we're gonna talk about the waveforms of the A line and the central line, right? So the A line waveform look like this, right? With the dichrotic notch, right? And So that's perfect waveform, right? How about if the waveform looks like this?
Excuse me, thank you.
Bless you.
Thank
More
you.
commonly, the most common thing when you see a wave that looks like this, it's lost the dichrotic notch and it looks a little stubby and rounded. And what is this? It looks more like a dampened waveform. And dampening of the A line is so common. Why? Because the way we tape it. People don't know how to tape A lines, right? So let's say I put an A line here or any place. If you see the needle, the way it goes, this is the A line, the needle always goes like this. The classic teaching is to go very steep on the needle, right? So you got the needle now. This is your skin, and that's the arteria, that's the artery here, okay? The needle went like this, so it goes like this. So I put a wire, and then over the wire I put the catheter, and the catheter looks like this now. And this is the tubing. What do we do with the tape? Let's put the tape like this, so basically this goes like this, and the tubing goes like this, flush with the skin. So we already created an almost 75-degree angle already. Add to it some edema, it'll be 90 degrees, and the thing is not working. There's a misconception that every A line that is not working, we have to take it out. No, that's not true. You can actually, call the provider. We will, undo it, pass a wire through, put a longer catheter, tape it better, whatever. We'll do whatever it takes. There's also other things. You flush. Sometimes we pass a wire through it to clear it up completely and come back. Sometimes we don't depend on a flush from here. We flush to this and use our manual, to
So how
flush
would you
it.
tape it better without putting it at that angle? How would you tape it better?
We do something what we call mesentery dressing. It's like a mesentery. You know the mesentery of the bowel? The bowel has mesentery around it, which is like the pericardium, but for the bowel. Right? So the mesentery goes like this. This is the bowel. The mesentery goes like this, touches underneath, and then spread. Like that. That's the way to tape it, not like this. You have to touch underneath. That's called mesentery dressing, or similar to the mesentery. It's a little bit a nerdy way to say just touch the dressing underneath. I love nerdy stuff.
No.
So this is a dampened waveform. We're gonna work on it. Let's say we worked on it and it's still dampened waveform. So chances are this is a cardiogenic shock. Just by looking at it. Just by looking at it like this, looks like cardiogenic shock. So see how important it is to work out the dampening, because if it's not, this is serious, this is cardiogenic shock here. Now how about this waveform here? It looks like this. Don't look at those for now, just look at this. How about those? What's happening here? So, see this? Anything, any opening, this area here is called area under the curve. That's actually how the LIDCO measures the cardiac output, actually, by measuring this area. When you see no area at all, like completely touching each other like this, that's an artifact. So this is called a spike or a flange or a flinge or something like this, a spike. So the blood pressure is not here. The blood pressure actually is here. But the machine doesn't know. It's gonna keep giving you blood pressure here. And it will actually screw up all of the LIDCO and all of these things. So that's called hyperresonant A line. So this is dampened, and this is hyperresonant A line. The hyperresonant A line is like, it's like crazy A line, like spiking like this, right? And that spike is not true. How does that happen? It happens with it's really a physics thing that hard to believe. Everything in the universe is oscillating. Believe it or not, I'm oscillating in front of you like this. But I'm oscillating so fast that your eyes cannot see how fast I'm oscillating. So you see me stable. This table is oscillating. This pen is oscillating. Everything is oscillating in the universe, but it's oscillating at 50,000 hertz, and you only can see up to 24,000 hertz, for example. So your eye cannot see. That's like the TV. They pass, the pictures, and the picture is so fast that you don't realize they are pictures. Actually, they're not video, but you see it as a video. So that's the same thing. So that if the oscillation of the A-line tubing, this one here, happen to be at the same oscillation of the A-line of the arterial wall, then it will spike like this. So it's a rare phenomenon. It happens, we've seen it, happens in maybe 1% of the A-lines that we do or something, and it just happens for no known reason. The only thing we do is tell the nurse, please change the A-line tubing, right? Otherwise this will. Okay, now how about this one here? That's why I told you don't look at this first. This is close to each other, so it's kind of confusing, but this is actually hypovolemia, and this is hypovolemia. So the hyperresonant waveform can also masquerade, or can be hypovolemia. So you have to rule out that it's hyperresonant. If you see something like this, change the A-line tubing. If it continues to be like this, chances are the patient is extremely hypovolemic, that there's nothing, there's no area under the curve. The heart is so empty that, that's why you're seeing this. So by vision, you can see this is cardiogenic shock, this is also hypovolemic shock, right? There's another thing by vision we see that can tell us if, without a machine, you don't need a machine, that can tell us if the patient is hypovolemic or not, which is what? Respiratory variation. Did I say the word respiratory? You're happy now? Basically, if this is the A-line goes like this, and the vent starts, during the breath, it goes like this. So during the positive pressure ventilation, the wave goes down like this, and then it goes up again. And the A-line starts reading, low, and then goes high again, and low and goes high again. And especially with the mode that we use, which is, 8 and 8. So you can see it actually. If you're using the mode that's like second and second, may not catch it. But for 8 and 8, you see it all the time. If you go to anyone on an event now, you'll see, a little bit going down like this. And if you see it exaggerated, like going down a lot, that means the patient is hypovolemic.
You can really see it on dialysis patients.
Do you see it on any other kind of breathing problems, like if somebody has corpulmonal, would you see it?
I don't, no, nothing corpulmonal, no.
No?
In fact, you don't see that you see it in precardial tamponade. Somebody's having precardial tamponade, you'll see something like this, exaggerated. But corpulmonal, I don't know, maybe we should look it up. But I'm not aware that you can see. Are you aware of?
I thought that was like one of the signs that they looked for. Blood pressure variation during respirations.
But vent respirations or?
No, it's like spontaneous.
Spontaneous, okay. Well, this only applies to vent.
Oh, okay.
Including, by the way, the LIDCO doesn't work, so the LIDCO has two, when we get to the LIDCO we'll talk about it, because, obviously we're not gonna talk about it today. But just a quick, thing, the LIDCO measures two things, measures the cardiac output and measure volume, right? And the way it measures volume only in intubated patients. If you have a LIDCO non-intubated patient, the volume measurement, which is called the SVV, it goes off the window because it hasn't been calibrated. Nobody could calibrate it for spontaneous breathing, but they could calibrate it to machine breathing, positive pressure. So maybe in spontaneous breath this happened, but I'm not aware. But anyway, so this one and this one, right? Remember, we're gonna keep fighting now in the room. Just say, your patient is very in cardiogenic shock. You need to do something about it. And I'm saying no, it's not in cardiogenic shock because X, Y, and Z. The A-line is kinked. You guys should tape it correctly and all of these things, right? So there's one test that we can do. The nurses do all the time, right? To test that and be the final arbiter and just say, here, I prove it for you. And that's basically called the square root test. Any questions so far, by the way? Okay. The square root test is like this. A-line goes like this, like this, like this. Then I pull that pigtail, the blue pigtail, flush it. And when it flushes, it continues the 300 millimeter of mercury directly to the artery. To the artery, right? So it will give you a pressure that above any measured pressure, right? On a monitor, we measure only up to 120, 140. So it goes up like this. And then when I leave it, it will spike like this. 1.5 times. If it spikes 1.5 times and go on to measure again, then that A-line is correct. The blood pressure that is measuring is correct, and at least for that limb. And there's no spiking, there's no over dampening, there's nothing. If it spikes like this, and go on to measure, that's a hyperresonant A-line. Don't believe it. It's actually measuring higher than what's supposed to be. The spike is there. And if it measures like this, no spikes, half a spike, that means that this is dampened. And it's very simple. Test can be done exactly in 2 seconds. And you'll know if you should trust your A-line or not. Now, we trust the A-line, but the blood pressure on the other arm with the blood pressure cuff is higher. Which one we're gonna take? No, no. The reason is people, our patients especially, have what? Have atherosclerosis. So they could have subclavian stenosis on this, and somebody ended up putting an A-line here, right? But the right arm has a higher blood pressure because his arteries are open. So you always take the higher. You always take the higher because unfortunately that's what happened, right? Okay, now the patient has a blood pressure cuff here and a blood pressure cuff on the ankle, or we moved it to the ankle. What's the changes that we're expecting?
Give me a second.
So that it changes from the arm to the leg?
Yeah, and a blood pressure cuff.
And blood pressure cuff.
So there will be a higher systolic,
A lower systolic.
yeah, and a
Yes.
and a lower diastolic, and of course, by definition, a higher pulse pressure. Pulse pressure is the difference between systolic and diastolic. So higher systolic, lower diastolic, and the pulse pressure, which is the difference between them, is higher, obviously, right? But same map. So that's why we go by the map. The map is the same, right? Okay. Another thing, blood pressure cuff. What's the characteristics of blood pressure cuff? We have a small patient over there, and we're using a big blood pressure cuff. It's gonna measure. It's gonna give you the impression that the blood pressure is low. You know, you have a huge guy with having a small blood pressure cuff. It's gonna give you the impression that blood pressure is high. So there are some measurement that people sometimes pay attention, sometimes don't pay attention to it, which is basically it has to cover 2/3 of this part here. If I'm doing it here or doing it here, it has to be 2/3 of the arm, right? The blood pressure, and it has to be wrapped at least 1.5 times, and then that gives you the. Okay, any questions so far? Okay, I'm gonna trust me. We are gonna go through this again, right? And next time there's gonna be questions. To see if people pay attention. But anyway, we're gonna go through it. But I'm gonna tell you quickly about the CVP waveform. So this way you know about it. But I don't think we have enough time to talk about all of the CVP. I'm just gonna tell you about it so you have it in mind. And then when we come the next time, we're just gonna decipher it even more, right? So the CVP is basically the measurement that they measure from the brown port, basically measuring the pressure inside the chest in the venous compartment, right? And usually we measure it right here. So this is the right atrium. This is the right ventricle, pulmonary artery, rest of the right ventricle, and then the left side, we can just draw it like this. Atrium and then ventricle here, and then goes the aorta. Okay, so forget about the left side for a second. The right side, what is this? Superior vena cava. That's SVC. Yes? And this is IVC. This is the inferior vena cava. So this is the biggest vein that comes from the right side, comes here, and the biggest vein that comes from the left, from the lower side, from the lower and upper parts of the body, and they all meet exactly. They're actually one line like this. Actually, they go in line like this. That's very important for ECMO. When we talk about ECMO, this lining up of the two veins like this is going to be very important. We'll talk about it. In fact, just to tease you a little bit, our catheters are going to end one here and one here.
So keep point that again?
One catheter is going to end here, and one catheter is going to end here.
Okay.
And there's another catheter that we use it maybe 5 years, 2 years, 1 year down the line. It's called the Avalon catheter that goes through. But we'll use that later. But for the ones that we're starting with, using one catheter here, one catheter here. Right? Anyway, so the catheter that goes from above, it ends here, and that measures the pressure inside the chest, you know, and that's the CVP really. The CVP ranges between 2 to 6. The normal CVP is 2 to 6, right? So why in sepsis we push it to 12? Because the patient is septic, is on pressure, so we have to push it to a higher number, because in septic patients, we don't know what the right side function is, or, you know, maybe the CVP is artificially high, maybe the patient has cor pulmonale, and that raises the CVP by itself without having fluid. So I don't have cor pulmonale, maybe I have a CVP of 6, and I have 100 cc's of fluid or blood in my atrium. Somebody else with cor pulmonale can have a CVP of 16, and he has 100 cc's of blood in his right atrium. So the CVP is a pressure measurement. It gives you the volume in a normal heart. Somebody who has a problem with the right side, the CVP could be completely wrong. What else do you guys do to change the CVP? Is the PEEP. You know, the more PEEP you give, the more increase in the intrathoracic pressure, and the CVP will be artificially high. Right? All of this we'll talk about the next time. All of the things that affect the CVP. But I want to leave you with this, because this, and so then because there will be questions next time. That is the CVP waveform, right? So when you see it on the monitor, it looks like a squiggly line like this. But if you pay attention, or have the nurse print it, it has to be printed, by the way, because the EKG,
It correlates.
it correlates with the EKG. So you know, if you look, the EKG, the sweep of the EKG on the monitor is slower than this sweep, so you're not going to be able to put them together. But if you print them, they're going to print together, right? And basically what it does, it goes like this. This is, the P wave goes here for the EKG. The Q wave, and then the R wave is here. And this is the T wave. It correlates with this. So that's T wave on the EKG, that's Q, R, S, and this is P. That's on the EKG. It correlates exactly like I'm drawing it like this for these waves. So let's just put names on this wave, and then we'll stop, and then you guys can want to read about it, or just remember everything, and then next time we'll talk about it. This is A, this is C, and this is V waves. Right? It's very easy to remember. A wave, C wave, and V wave. A is for atrial, C is for contraction, V is for venous return. It's very easy. Venous return, contraction, and A is the atrial contraction. So if you think about it, after the P wave, this is the electrical impulse that actually starts the impulse. The atrium contracts, not the ventricle, the atrium contracts. That's the atrial contraction. That's the A wave. And then a C wave, that's when the valves close. So now, after the atrium contracts, the blood goes from the atrium to the ventricle, right? And now the valve, the tricuspid valve needs to close. Need to do like this. As it's doing like this, it makes a blip of pressure, like a small wave. So that's the smallest wave of the EKG, of the CVP, is called the C wave. Just a little blip like this, because I'm measuring pressure here, and it gives me a little bit of blip. And then after that blip, now if you think about it, now we have the valve closed, right? So what do you think is going to happen after the valve closed? The ventricle is going to start to press, right? And the ventricle presses like this. It doesn't press only like this. It has also the papillary muscles and the cords that pulls the annulus down. This is called the annulus here. It pulls the annulus like a piston. It's like something goes like this, so blood comes out from the pulmonary artery. So as it's pulling down like this, if you can imagine, this part moves here. Then the atrium is bigger. Then it creates a vacuum in the atrium. It creates this descent here. It's called the X descent, right? And after the X descent, after the ventricle pulled out like this and pushed the blood out, right? What's going to happen next? The blood is going to come back to the atrium to fill it, and that's the venous return. That's the biggest wave, the venous return. And then after the venous return, it repeats again, A. You know, the atrium contracts again. And this is called the Y descent. The Y descent is the valve opening. After the venous return happened, the valve just open, and everything here empties into here, so it gives you a big, huge descent here, the Y descent. So this A, C, V, and then you have the X descent and Y descent. This is important to diagnose some diseases, pericardial tamponade and stuff like that. Hopefully we won't see it, but some people will develop precardial tamponade on ECMO, because you're playing with big catheters and the patient is anticoagulated like crazy and all these things. So if somebody astute and show and sees this, like the wave looks like this, like a square wave, looks like this, like A, and then all of those look like they're the same, and going down like this. If you see A and then this looks like this looks like the square wave, root wave, and that's pericardial tamponade. Something happened to the patient. There's other signs of course, but that's it. All right, that is it for today.
Until next week.
Until next week. Any
You want me to
questions?
stop
Wait.
it? Oh, all right.
Any questions? Let's see if did you guys see anything?
Yeah, it's harder to see the whiteboard, but I can grasp it, I think.
So, any questions? All right, so for today, forget about the CVP. This is just a teaser. But for next time, there will be questions about the A line. I'm gonna ask everything about the A line, and then we'll move on to CVP. All right, thank you, professors.
Perfect, thank you.
Thank you.
Thank you.
Thank you, Howard.
Now do you want me to shut it?
Yeah.